Good evening, everyone. Welcome back. And I would once again like to invite you for the second episode of Applied Immunology webinar series. As you know that we have started the series yesterday with a bank on immunology, and in this we have already discussed about the basics of immunology, various cytokines, inflammatory markers, different immunoglobulins, and the type of immunoglobulins and how they are produced, how they are structurally different from each other, and what are the functions, the physiological functions in the body, and what happens when the things get deranged. And then simultaneously, we also discussed about the laboratory diagnosis, that what to order, when to order, and in which conditions it is usually helpful to us. And now, building upon that knowledge, now we will move further. And today is a very important day in which we'll be discussing, I will say that, a more relationship to the clinical entities, different allergic disorders, and about their immunological phenomena and how they are actually correlating with the clinical picture. So, for which I have once again expert team with me, and to moderate the session, I would first like to invite Dr. Smita Satapathy. So, she is a professor in the Department of Pediatrics at IMS and some Hospital, Bhubaneswar, and she is a trained allergist and a pediatrician, and having a deep interest in pediatric pulmonology also. So, Dr. Smita, thank you very much for accepting our invitation, and you can start now.
Thank you, sir. Without much delay, I would like to welcome you all to the day 2 of this brainstorming webinar series by the Immunology chapter, Allergy chapter of IAB. Yesterday, as rightly sir has said, that we have focused our discussions on various basics of the immunology and allergy, where we talked about the allergic orchestra, the cells involved, the immunoglobulins, the cytokine milieu. Now we'll be focusing mainly on some case-based discussions in which we'll be talking about various immunological disorders and the immunological basis and how they line up. Here we'll be discussing about the immunological practice on allergic asthma, rhinitis, about the food allergy, the immunological basis of the much important topic like anaphylaxis, and also about the immunotherapy about its immunological basis. We have a wonderful line of speakers. Without further ado, I would like to invite our first speaker, Dr. Shebna Kedar, to talk about the immunology of asthma and allergic rhinitis. Dr. Kedar, she is a MD Pediatrics, has done her DPA and FAP. She has affiliated to Allergo Kids Pediatric Allergy Clinic in Kochi. She has various publications in many international journals, contributed to chapters in the 4 textbooks of allergy, has been faculty in various national and state conferences. I welcome you, ma'am, to start your session. Thank you, ma'am. Ma'am, you may share your screen.
Yeah. Are you able to see my screen?
Yes, ma'am.
Okay.
Just a slideshow, ma'am.
Yeah. Yeah. Is it visible?
Yes, ma'am.
Audible too, right?
Yes, ma'am.
Okay. So thanks a lot, Dr. Smita, for that nice introduction. And thanks a lot, IAP, Allergy and Applied Immunology chapter, and Neeraj sir for inviting me for this session. And it is always a pleasure to see so many educational activities being conducted by the chapter. So congrats to Dr. Neeraj and the whole team behind it. And straight away going to my topic. It's the immunology of asthma. Just 1 minute. Immunology of asthma and allergic rhinitis, mainly the Th2 skewed pathway and the IgE mediated one. So whenever you talk about immunology, there are so many cells involved, there are so many cytokines involved as discussed yesterday. And when you are reading more and more, it make you more confused. So in this topic, I know it is a vast topic. I have tried to make it simple and focus more on the clinical aspects and also the treatment aspects. So I'll be dealing mainly about the Th2 skewed pathway, the cytokines involved and actions, the clinical relevance in asthma and allergic rhinitis, then immunology-based treatment in short. So the asthma and allergic rhinitis, as you all know, it's a unified system. So I'll be dealing first with the asthma, mainly eosinophilic type allergic asthma. And then I will be going to the allergic rhinitis, just the changes that are there in it. So allergic asthma, eosinophilic type. So I know that all of you will be familiar with this diagram, that is the type 1 hypersensitivity 1, and it is mainly responsible for the allergy. So I have just marked some points and I will be just brushing up on this diagram. The first one is, so whenever there is an allergen or antigen exposure, the antigen will be presented by the dendritic cell, that is the antigen presenting cell, to the naive T cell. That is the first part. And the second one is the naive cell. There will be it can either go on to the Th1 pathway or the Th2 pathway. And in allergy cases, it is the Th2 pathway that is getting activated. And the third one is the Th2 cell in turn activate the B cell, and plasma cells will be formed, resulting in IgE secretion. And the IgE is released and then it gets bound to the mast cells and basophils. The Th2 cytokines that are released will be primarily IL-4, IL-5, and IL-13. And out of that, the IL-5 one is the one that is activating the eosinophils, resulting in the immune response. And the fifth one shows the effects of IL-4 and IL-13, resulting in bronchial hyperresponsiveness, increased mucus production, and all. And in allergy cases, there will be re-exposure. When there is re-exposure to particular allergen, the mast cell and basophil gets degranulated, releasing the mediators. So what is actually the Th2 skewing? Why is it happening? There are multiple factors that are happening, that are behind it, mainly the host factors and environmental factors. So the host factors are the factors that can change the cytokine balance, that is infections, then antibiotic usage in the early life, then dietary habits like early introduction or late introduction of food, then repeated allergen exposure in the early life, then genetic factors are filaggrin gene mutation. Then gender also is important. Like in the initial phase, it will be mainly the male preponderance, and later on, after puberty, we can see a female preponderance. And the environmental factors are also playing a great role in the Th2 skewing, like allergen exposure. Then pollution is becoming more significant nowadays, and infections, especially RSV infection, adenovirus, mycoplasma infections. So all these factors will change the Th1 pathway to more towards the Th2 type. So as I have told already, like environmental factors and the genetic factors are very important, resulting in the Th2 inflammation. And the key components are allergic inflammation by the IgE mediated one, then epithelial barrier dysfunction, eosinophilic inflammation, and in atopic dermatitis and allergic rhinitis and all, there will be one more factor, that is neuroimmune dysfunction. So first of all, we'll take one by one. The epithelial barrier dysfunction, it is actually a common factor for both eosinophilic and neutrophilic pathway. It is also common for all the type of allergic disorders, and there will be loss of epithelial cell morphology. The filaggrin deficiency also plays a part in that, and this results in loss of antimicrobial defense and also increased release of the immune triggers. Then there will be more chances of fibrosis and tissue remodeling. And as you can see, there will be release of several epithelial-derived alamins, which are very important. So the epithelial barrier, one thing I want to add is whenever there is epithelial barrier dysfunction, the severity of the illness will also increase. So in cases of atopic dermatitis and all, if a child is having asthma, there are more chances for it to be more severe. And the toll-like receptors on the cells again will stimulate the production of epithelial-derived alamins. So these are very important in the management of asthma also. So the three alamins are IL-33, IL-25 and TSLP. So IL-33, it acts on the immune cells directly and it is more seen in eosinophilic type of asthma. IL-25, it is also seen in eosinophilic type and it again increases the chance of airway hyperresponsiveness and also increases the tendency for Th2 skewing. TSLP is very important in the management. It acts on innate lymphoid cells type 2 and the high levels are often associated with disease severity. Then there are more chances for corticosteroid resistance and it is not just for eosinophilic asthma, it can be seen also in neutrophilic type. So this is the one that is TSLP acts for the allergic inflammation, eosinophilic inflammation and neutrophilic inflammation in asthma. And the monoclonal antibody that is acting against this is tezepelumab, which acts in the initial phase. Thereby we can prevent the cascade being happening. And it helps to reduce the asthma exacerbation, the symptoms, and also improve the lung function. So these are the functions of the alamine. As I have told, like it acts directly on the mast cells, directly on the basophil, eosinophil, and dendritic cell. So this actually increase the inflammation not just by the Th2 skewing, it acts directly on the cells, resulting in the cascade being carried on. So dendritic cell, I will just start from the beginning. The dendritic cell, it is very important because it is not just an antigen presenting cell. It also increases the Th2 skewing. And it is specifically triggered by alamins. And dendritic cells, when exposed to antigen or allergen, it migrate to lymph node and then present it to the naive T cell. And these are also drivers for eosinophilic inflammation, accumulation. And Th2 cell triggering is also another function of dendritic cell. So we need to know that it is not just an antigen presenting cell. Now about the Th2 cell. As you all know, it is a major pathway of airway inflammation and the action is mainly based on Th2 cytokines. And the alamins that we have mentioned already, that is IL-33, it also helps in the cytokine release. And the cytokines that are released from the Th2 cells are mainly IL-4, IL-5, IL-13, and IL-9. So IL-4, it induced the IgE class switching by B cell and it acts through IL-4 R alpha receptor and the actions are mainly increasing the bronchial hyperresponsiveness and increase inflammatory cell extravasation, which are the main pathological features of asthma. And IL-13, this also acts through IL-4 R alpha receptor and has action similar to that of IL-4. and it has an additional role in airway remodeling. So the point that has to be noted is IL-4R alpha is the receptor for both IL-4 and IL-13, and anything that can block that receptor helps in reducing the function of IL-4 and IL-13. And IL-5 is mainly related to eosinophil that helps in the recruitment and also activation of eosinophil, thereby increasing the airway inflammation, the mucus production and all. So this is the summary of what I have told just now, and that is IL-5, IL-4 and IL-13 causing its actions. And the new players that we don't discuss usually are IL-9, which is a key therapeutic agent actually, and researches are more going on, and because it has a central role on all the cells of inflammation, and it results in airway hyperresponsiveness, mucus production, remodeling, and also eosinophilia. So all these are main features of asthma. And if there is any drug against the IL-9, it will be more effective. And TRM is resident memory T cell. These are the T cells which are similar to Th2 cells, but produce more cytokines than Th2 cell. And on re-exposure to allergen or antigen, there will be direct reactivation, which is more rapid than the Th2 activation. So this is in short about the monoclonal antibodies. The first one is tezepelumab that acts against the TSLP, which I have already told, and blocking the first step itself. And the IL-5 that is seen as a pink dot is mainly related to the eosinophil inflammation, and that is blocked by the mepolizumab and restylizumab. And the receptor is blocked by benralizumab, thereby inhibiting the action of IL-5 and reducing the eosinophil. Dupilumab, actually, this is what I told, like IL-4R alpha receptor is blocked and thereby reducing the function of IL-4 and IL-13, and it will be having more effect than the other monoclonal antibodies. And another cell which is very important, similar to Th2 cell, is ILC2, that is innate lymphoid cell type 2. And these are regulators of innate immunity, and they trigger the inflammation and is also helpful in tissue repair. These also, similar to the Th2 cell, respond to epithelial alarmins, and the actions are similar to Th2. And the important point is IL-13 that is released specifically from, innate lymphocyte. It disrupts the epithelial barrier, thereby it acts like a vicious cycle, triggering the inflammatory pathway. And again, it acts earlier than the Th2 cell, so it causes an immediate inflammatory response and also stimulate the dendritic cell migration to the lymph nodes. So these are the actions of ILC2, and note that it again trigger the epithelial cell damage. And B cell is like Th2 interact with the B cell, resulting in plasma cell activation and IgE release, and it can be seen in lung tissue and lymph nodes. The IgE that are released bind on the mast cells and basophil. So that is the initial phase, and the binding is the key in all the inflammatory cascades. So whenever there is another activation like re-exposure to allergen or antigen, there will be like activation of the mast cells and basophil. For that, the two adjacent similar IgE is needed, and one allergen can bind to two adjacent IgE, and then only the mast cell and basophil will be activated. And this release result in the release of the mediators, which can be either preformed mediators like histamine or tryptase, or newly synthesized mediators like leukotriene and cytokines. And IgE directly can increase the vascular permeability and also increase the mucus production also. So this is what I told just now. The two adjacent IgE, when bound to the allergen, stimulates the mast cell release of the mediators. So mast cell, it is having like action on various cells like the dendritic cell, endothelial cells, T cell, macrophage, and natural killer cell. And the special mention has to be like the mast cell acts on the smooth muscle cells also, and it changes the phenotype to a more contractile phenotype. So what happens is like when the mast cell activation is there, it indirectly stimulates the airway hyperresponsiveness. And also the fibroblasts are also getting activated, resulting in increased collagen formation and tissue remodeling. The eosinophils are main cells of Th2 inflammation, and the IL-5 is the key cytokine for maturation and activation, and it has immunomodulatory action and also pro-inflammatory action. So it exerts effects through cytotoxic proteins and thereby resulting in bronchial hyperresponsiveness, goblet cell hyperplasia resulting in increased mucus production, and also has a role directly on the airway remodeling. So these are the effects of the eosinophil, and it releases the cytokines resulting in various effects, which are a major factor in the pathogenesis of asthma. Basophil is as important as mast cells and release the mediators on re-exposure. So basophil, release the mediators to the, it's mainly found in the bloodstream, and mast cells are mainly found in the tissues. And special mention has to be there for Treg cells, that is T regulatory cell. It is actually an auto-regulatory cell. Now, it actually inhibits the allergen response, and it is very important in the immunotherapy aspect. This is a beautiful diagram explaining what all I have told just now. And the top part, it shows the Th2 low and Th2 high pathway, and then explaining the epithelial alarmins, then all the cytokines, the actions of the cytokines, and also in the lower part, they are showing the effect of various like treatment modalities on the each type of asthma. So I'll be sharing the article from which I have taken. It is worth reading. So this is in short about the treatment modalities that we see nowadays, like the monoclonal antibodies. So the omalizumab is acting against the IgE, that is the last stage of the inflammatory pathway. And dupilumab, as I have told already, it acts on the IL-4 R alpha receptor, thereby inhibiting the actions of IL-4 and IL-13. And benralizumab and mepolizumab are acting on the IL-5, and tezepelumab acts on the TSLP, that is the initial phase. So now I'll be just going to the allergic rhinitis part. So the allergic rhinitis, the initial phase is exactly the same as allergic asthma. The change happens only in the lower part, that's the release of the mediators. So it has an early phase and late phase response. So allergic rhinitis, the mast cells are the main cells, and it has a typical type 1 hypersensitivity response with a sensitization phase, that is the triggering by the first exposure of allergen. And whenever there is re-exposure to allergen, there will be the response phase, resulting in the mediator release. And in that response phase, it is divided as like early phase in case of allergic rhinitis and late phase also. So the early phase is within 5 to 15 minutes, and it's mainly because of the mast cell degranulation. And the early phase is basically mediator related. That is, inflammatory mediators are released, out of which histamine plays a very important role, and it is a primary mediator, resulting in sneezing by a trigeminal and rhinorrhea by the stimulation of the mucous glands, and certain other mediators like leukotriene and prostaglandins are released, resulting in nasal congestion. This is the early phase, which happens immediately after the allergen re-exposure. And the late phase usually occurs after like around 4 to 6 hours, and it is mainly the cellular response. The other one was mainly mediator response. So the cellular response is mainly by the cytokines released by the Th2, that is IL-4, 5, and 13, and it is mediated by basophil, eosinophils, and neutrophils, and resulting in mucosal edema and nasal congestion. So the early phase result mainly in the sneezing and itching and rhinorrhea, and the late phase mostly causes nasal congestion. And there are so many non-IgE mediated pathways also in allergic rhinitis, but my topic is restricted to the IgE one. So these are two articles which helped me to clear this topic, and this is actually worth reading, and these are two new articles, comparatively new articles. I know that it was a vast topic, and I have tried my level best to make it simple, more to the clinical point of view. So sorry if I have missed anything like which you really wanted. So thanks a lot, everyone, for your patient listening.
Thank you, ma'am, for that clear and informative session in which you have covered not only about the basics of cells involved, also about the alarmins and also about the targeted therapy which is available for both asthma and allergic rhinitis. It was a very lucid interactions. Now we'll move on to our next session, which will be by Lieutenant Colonel Dr. Gururaj Ramaya. Welcome, sir. Welcome, sir.
Thank you, madam. Thank you.
Sir is currently working as consultant pediatrician in Military Hospital, Jodhpur, Rajasthan. He has done his MD Pediatrics from AFMC Pune with DPA from Sri Gangaram Hospital with gold medal. He has also done his Diploma of Pediatric Sleep Medicine from University of Colorado, USA, with various publications, various national and international journals, and being a faculty in many national state conferences. I welcome you, sir, to start the session. Thank you, sir.
Thank you, ma'am. Is my screen visible, ma'am?
Yes, sir. Just a slideshow, sir.
Yeah.
Yes.
Can you see my screen?
Yes,
Am I
sir.
audible?
Yes, sir. You are audible also.
Thank you very much, ma'am, for the kind words.
Thank you.
First of all, thank you very much to IAP and Pediatric Allergy and Applied Immunology chapter and Neeraj sir for giving me this opportunity. So I'll be discussing about food allergy and applied immunology facts. The outline of my presentation is food allergy and versus food intolerance, differentiating that, and oral intolerance, and the role of gut-associated lymphoid system, the triad of oral tolerance mechanism, and IgE-mediated food allergies, non-IgE-mediated, role of Treg cells, role of microbes in food allergy, and applied immunology in diagnosis of food allergy. Food allergy is perceived as perceived food allergy is more common than the true food allergy. True food allergy is immune mediated, and true food allergy is reproducible. So coming to allergy versus intolerance, the terms food allergy and intolerance often used interchangeably. Food allergy is an immune process, and whereas food intolerance is non-immune reaction that primarily involves digestive or metabolic systems. So main difference is in food allergy, the system involved is immune system. In food intolerance, it is digestive or metabolic system. So in food allergies, mechanism Ig and T cells, mast cells, whereas food intolerance, it is enzyme deficiency like the lactase and chemical sensitivity. The trigger amount, potentially microscopic in food allergy, whereas food intolerance is dose dependent. The onset of symptoms is rapid in food allergy, whereas Ig mediated, it's less than 2 hours. Food intolerance often delayed for hours to days. Food intolerance, allergy is life-threatening in the form of anaphylaxis. It involves multi-systems. Food intolerance, nothing of that sort is this one. So primary treatment in food allergy is strict avoidance and epinephrine and various other modalities. Whereas food intolerance, it is dietary modification and enzyme supplements. So coming to oral tolerance, this is the immune system's default setting. The immune system's interaction with the external world is a constant balancing act between defense and tolerance. Nowhere in the body and no other system than the GIT, which is exposed to an immense and continuous load of foreign antigens from food. The default healthy response to this challenge is not attack, but a highly regulated state of non-responsiveness, which is known as oral tolerance. The failure of this fundamental process is a central event that precipitates the development of food allergy. So oral tolerance is an active antigen-specific suppression of cellular and humoral immune responses following the oral administration of an antigen. This is not a state of immune ignorance, but rather a learned and maintained hypo-responsiveness. The gastrointestinal tract encounters around 30 kg of different food proteins annually. So the necessity of this maintaining homeostasis is quite clear. The breakdown of this establishment or maintenance of oral tolerance directly results in food hypersensitivity. So this is GALT, gut-associated lymphoid system. This is the immune decision-making hub, which consists of the lamina propria, Peyer's patches, the epithelium. These are main things. The players are, this is an anatomical and functional nexus of oral tolerance. It's the largest and most complex component of immune system, which consists of around surface area of around 260 to 300 meters square. And it is strategically positioned to guard the permeable mucous membrane barrier and tasked with a dual mandate of defending against pathogens while tolerating harmless antigens like food antigens and the commensal microbiota. The GALT has divided into two functional compartments: inductive sites such as Peyer's patches in the intestine, the appendix, and numerous isolated lymphoid follicles. These are primary locations for antigen sampling and the initiation of immune response. Peyer's patches, as I shown in the figure, these are Peyer's patches, they are equipped with M cells, which help in transfer of antigens to the dendritic cells and transport the luminal antigens to the subepithelial dome, a region rich in antigen-presenting cells, like the dendritic cells and macrophages. This antigen-presenting cells process the antigens and prime the adaptive immune response. Whereas the diffuse lymphoid tissue, which is present in the lamina propria, it is involved in, it consists of effector cells, like T cells, plasma cells, mast cells. It is scattered throughout the lamina propria and execute the immune process. So the diverse gut microbiota provides continuous stimulation while maintaining the gut-associated lymphatic tissue in a state of chronic controlled activation and sustaining the germinal centers necessary for a robust and well-regulated immune system. So what is oral tolerance? A state of immune unresponsiveness to food antigens. This is a normal phenomena and this is essential. Otherwise, we all would be allergic to every food. T regulatory cells are inducted to produce energy, that is a non-responsiveness. The intestinal epithelial cells are non-professional in presenting the antigen to T cells, hence no response. Dendritic T cells in the Peyer's patches produce IL-10 and IL-4 and favor tolerance. And breastfeeding in infants promotes oral tolerance. So there is triad of immune tolerance. So what is this? This has three components. One is the barrier, which is the epithelium, the sampling, the processing of antigens from the outside, luminal, to the inside, and the regulation, which I'll be telling later. So first, let us talk about the epithelium. The intestinal epithelial barrier is the primary defense. It is a single layer of epithelial cells linked by tight junctions, restricts the uncontrolled passage of luminal antigens into the underlying tissues. When this barrier is compromised by inflammation or dysbiosis, the mucosal membrane becomes overexposed to dietary proteins. So there will be a breach, and that leads to production of alarmins like TSLP, IL-25 and IL-23, and the individual become the pro-allergic type 2 T cell response. So this a leaky gut is therefore a dysfunction that promotes inflammation that further exacerbate the allergic predisposition. Secondly, under homeostatic conditions. So we should remember that barrier integrity is not just a physical concept. It's an immunological state actively maintained by healthy host microbe relationship. So next step is antigen sampling. So in this, antigen sampling is a tightly controlled process. Specialized dendritic cells in the lamina propria extend dendrites to the epithelial cells to directly sample antigen from the gut lumen. These tolerogenic dendritic cells then migrate to the draining mesenteric lymph nodes, and where they present the food antigens to native T cells in a non-inflammatory context influenced by local factors like retinoic acid and microbial metabolites. Finally, the tolerogenic. There is a role of T cells here, Treg cells. So the Treg cells are the critical step in maintaining the balance between allergy and the normal state. So ultimate fate of immune response to a food antigen, whether it results in tolerance, allergy, is determined by the critical balance between pro-allergic Th2 cells or immunosuppressive Tregs. In healthy individuals, a robust population of antigen-specific Tregs maintain a state of tolerance by actively suppressing Th2 responses. Tregs employ a variety of suppressive mechanisms. You can see this here, IL-10, which is inhibitory cytokines and inhibits effector T cells. And there are a process that's going on, cytolysis, apoptosis of the T cells. So they produce anti-inflammatory cytokines like IL-10 and TGF-beta, directly induce apoptosis in effector T cells and modulate the function of dendritic cells to promote a more tolerogenic state. In individuals with food allergy, this regulatory arm of immune system is often compromised, with evidence pointing to either a numerical deficit or a functional impairment. There's enough studies which demonstrated that infants with food allergies exhibit a lower ratio of Tregs when compared to effector T cells. Crucially, there is some evidence that Treg deficit may be a cause rather than a consequence of the allergic disease. So this is what I was telling. In a healthy individual, there is a wonderful coordination between the commensals and short-chain fatty acids, and there is ultimately inducing Treg cells and avoiding an allergic Th2 response. Whereas whenever dysbiosis happens, leaky gut happens because of various reasons. So there is production of activation of Th2, production of activation of B cells, and production of IgE, and going and sitting in mast cells and producing allergic response. So next, basically, it is the type 2 immune response. It's the hallmark of allergy. It is a pathway to allergic disease, begins when the homeostatic balance in the mucosal barrier is disrupted, and perturbation in the gut or the skin barrier. Skin can trigger a release of alarmins, which I discussed earlier, which act as danger signals, chemical sirens to induce immune system. These signals instruct antigen-presenting cells to prime Th2 cells and to produce food allergy. So, what is the central role of IgE, mast cells, and basophils? The production of allergen-specific IgE initiates the sensitization phase of allergic response. The allergen protein cross-link the IgE molecules bound to the surface of mast cells and basophils, triggering a rapid and explosive degranulation. This process releases a potent cocktail of preformed inflammatory mediators like histamine, tryptase, and so many. This is followed by rapid synthesis of powerful mediators like leukotrienes and prostaglandins. And these mediators are responsible for acute clinical symptoms of food allergy. So, while everyone, the normal thinking is the final executors of allergic reactions are mast cells and basophils, they play a very complex role. Upon activation, they also serve as important source of IL-4. So this creates a potent positive feedback loop. An initial Th2 response to some IgE production and subsequent mast cell activation. These mast cell activated mast cells release more IL-4, further promotes Th2 differentiation and suppress the development of Tregs. This mechanism transforms the mast cell from a simple effector cell to an active adjuvant of allergic response, helping to explain chronicity and self-perpetuating nature of the allergic inflammation. So what causes impaired immune response in food allergy? So we have so many, the genetics, we think the genetics explain everything. No, it is not the case in allergy, food allergy particularly. So there was hygiene hypothesis, which was proposed in 1989, which said that epidemiological observation that children from larger families who presumably be exposed to more infections had a lower incidence of allergy, particularly allergic rhinitis. This initial theory informed about a lack of early infections led to improperly tuned immune system, leaving it to skew towards to Th2 state. Over time, this hypothesis evolved. Now, widely understood that critical missing exposures are not common childhood illness, but rather vast and diverse array of commensals and environmental microbes, often termed the old friend hypothesis, in which humans and microbes existed together. Factors associated with westernized lifestyles, urbanization, smaller family size, antibiotic use, sanitation have dramatically reduced our exposure to the microbial diversity. So this microbial deprivation is thought to impair the normal maturation of immune system. The modern interpretation is strongly supported by consistent findings that children raised in traditional farms with high level of animal and environmental microbial exposure have significantly lower rates of allergic diseases. Next, the gut microbiome. It's a master regulator of immune development in food allergy. So it has been proven that first 1,000 days of life in children is a critical window during which infant gut is colonized by microbes that in turn educate and program the developing immune system. The key perinatal factors like mode of delivery, vaginal versus cesarean section, and infant feeding methods like breast milk, which contains complex oligosaccharides, which help in promotion of growth of beneficial bacteria, and early antibiotic exposure, all have a profound and lasting impact on the composition of foundational microbial community. A microbial signature or dysbiosis has been identified in children with food allergies. I just want to, I just want to go back. I just want to highlight one fact that genetic does not explain. It is a genetic that loads the gun and the environment pulls the trigger. This I learned from Dr. Neeraj sir, who taught me during the course. So this means has lots of meaning. It's a genetic that loads the gun and the environment that pulls the trigger. So continuing about the role of gut microbiome, the early antibiotic and food allergy can be conceptualized as a disease of microbial loss because microbes strengthen the intestinal barrier and they ferment dietary fiber to produce immunomodulatory metabolite like short chain fatty acids, which will convert to the butyrate, which help in powerful inducer of Treg differentiation. All our cells contain an important receptor like GCPR43, that is G protein coupled receptors. All our cells, only the microbes, short chain fatty acid like the metabolites of short chain fatty acids like butyrate, they bind and they can powerfully induce of Treg differentiation. Because everyone says consume fiber. The fiber has so many important advantages to our health, but we don't have any enzymes to digest the fiber. So it is only these fibers are required for our commensals. That's a point I want to highlight. So this dual allergen exposure hypothesis is a very important and provided unifying network that connects environmental exposure and barrier integrity. The root of allergen exposure can explain development of food allergy. This theory shown that the immune outcome determined by the site and dose of the allergen exposure. Low dose exposure to the skin, particularly through an inflamed and compromised skin barrier that happens in atopic dermatitis, promotes allergic sensitization. In contrast, early and high dose exposure in the gut promotes the development of tolerance. So that means skin is allergic prone and gut is the tolerance prone. Okay, that's a very, very important thing. This hypothesis elegantly explained the well-established clinical observation that atopic dermatitis is a major risk factor for subsequent food allergy, which this also shown the prevention strategies which are moved away from the allergen avoidance towards the early oral introduction of allergic foods. The gut-skin axis appears to be a critical pathway in the allergy development. Gut dysbiosis is known to be associated with atopic dermatitis, and gut-driven skin inflammation can compromise skin barrier, creating an entry point for environmental food allergens like peanut and transcutaneous exposure that leads to systemic sensitization, establishing a clear mechanistic pathway. So gut dysbiosis contribute to skin barrier dysfunction, which in turn facilitates the allergic sensitization to food. So these are the immunological adverse reaction to food, which is commonly Ig mediated, non-Ig mediated, and mixed. So Ig mediated we know very well: oral allergy syndrome, contact dermatitis, urticaria, angioedema, asthma, anaphylaxis. So non-Ig mediated, we have food protein induced enterocolitis syndrome, food protein induced allergic proctocolitis, celiac disease, food protein induced enteropathy, and Heinous syndrome, all of this. And mixed are eosinophilic gastrointestinal disorders. So the major difference, I want to just go through this: Ig-mediated food allergy and non-Ig-mediated food allergy. Ig-mediated involves many systems, whereas non-Ig only GIT. The timing is within 2 hours, and in non-IG is hours to days. And IG mediated can be severe and lead to anaphylaxis, and there's no anaphylaxis in non-IG mediated. Pathogenesis is type 1, IG mediated, and in non-IG type 3 or type 4. Example, peanut, and milk, and many other. And celiac disease in non-IG. So in IG mediated, as I explained earlier, that's very clear. There is a barrier, and an antigen breaks and taken up by dendritic cells, and which is presents to NAV CD4 and release of IL-4 and IL-13, and directs the B cells to produce the IgEs by cross switch, and the plasma cell which creates by cross switch IgE, and which goes and binds to mast cell, and next time when the same antigen, it will just explodes and lead to so many reactions. So coming to non-IgE, the immunology of food protein-induced enterocolytic syndrome, whereas here we can see the mechanism is still being investigated. There's one, the food protein that comes and enters, presents taken up by the dendritic cells, and it presents to T lymphocytes. T lymphocyte produce interferon gamma and TNF alpha highlight, which stimulates the neutrophils and goes and start inflammation in the luminal layer. And there is decreased TGF beta and inflammation. There is increased permeability. There is fluid shift. There are lots of dehydration here. FAS is quite severe, and clinically they present with severe diarrhea, dehydration, and very toxic. So there is also eosinophil because it produces IL-4. So coming to the immunological basis of food protein-induced allergic proctocolitis, if the protein comes and taken up and directly enters the intracellular, and where there is eosinophilic proliferation, there is decreased TGF beta, there is also fluid shift here, and there is involvement of eosinophil here. So coming to immunology of food protein-induced enteropathy, here it is taken up by dendritic cells, presents to T cells, there's IL-4 and interferon gamma. So there is also involvement of cytotoxic T cells, and here also T cells go to cause mucosal damage and villus injury. This is a chronic infection, presents as failure to thrive, diarrhea, and all those things. So immunology of eosinophilic esophagitis. Here, this is a mixed IG and non-IG. The food protein enters, antigen presenting cell, Th2, involvement of eosinophils. There is mast cell. There's involvement of inflammatory the markers like IL-13, 4, and 5. There's growth, activation, translocation of eosinophils. The most important mechanism here is the presence of eosinophil in the gut epithelium. So it can present as eosinophilic esophagitis, eosinophilic gastritis, eosinophilic jejunitis, all those. So and it can lead to chronic things like fibrosis and many other clinical features. So coming back to, there is a concept of immune regression in food allergy. Here you can see that many foods are there. So and they peak in some years and they come back and come back to normal levels. So every food has different story. So this concept I want to highlight is, it is outgrowing of food allergy, natural resolution of food allergy, more prominent in egg and milk allergy, whereas milk allergy the peaks in first year and comes back by 80% by 2 years, and egg allergy comes back by 3 to 4 years. And why this happens? What is the immunological basis? Is decline in specific IgE, increase in IgG4, which is a blocking antibody, and increased activity of T regulatory cells. So coming to the precision, the diagnosis. So the diagnosis of food allergy historically has fought with so many uncertainties. The conventional skin prick test, or IG levels in the serum, they identify sensitization. But mere presence of IG antibodies does not always correlate with a clinical allergy. This ambiguity frequently necessitates the oral food challenge, which is the gold standard, but it is resource intensive and potentially dangerous because of anaphylaxis risk. However, the field is rapidly advancing and moving towards a precision diagnosis and this one. So I don't want to discuss the convention test. I mentioned the limitations, but they have still lots of role if the history is good. So coming to the component resolved diagnosis, it is a major leap towards the allergen testing. Instead of using a crude extract of food from a food source, the CRD measures serum IgE of an individual, purified proteins or components within that food. This is a molecular level analysis, provides much more detailed picture of a patient's sensitization profile. The clinical utility is multifaceted. First, it can help distinguish a true primary food allergen from clinically less significant cross-reactivity. That's for example, and other thing is, if we detect RH2, we can predict a severe reaction. We have to give that straight away, give epinephrine injection for the future to prevention. So RH2 we can be a little bit relaxed it can cause mild reaction. So come to hazelnut, core A9 and core A14 can cause severe reaction. So what the CRD is doing is enhance diagnostic accuracy by discriminating between true sensitization and cross sensitization. It also helps to determine the natural course of allergy. So coming to basophil activation test. So why this is in relation to food allergy, this is a food challenge in a test tube. So it's an in vitro test. So here we are seeing resting basophils and activated basophil. When this resting basophil is provided with the allergen of the incubated with the suspected allergen, this we can see CD203 receptors, they upregulate, they increase in number. You can also see in the resting basing cell basophil, the CD63 is inside. So whereas activated basophil, there is expression of CD63 on the membrane, and we can detect in the flow cytometry. So we can see this in the mast cell activation test. So this similar, this is the flow cytometry diagram. So unactivated, inactivated, you can see this CD63 on the right hand side. So coming to therapeutic frontiers, retraining the allergic immune system. So for many years, the management of food allergy was confined to a defensive posture, strictly dietary avoidance and ready availability of emergency epinephrine. Now it is being replaced by proactive approach centered on active therapeutic interventions. These strategies like allergen immunotherapy designed not just to manage symptoms, but fundamentally retrain the allergen immune system towards a state of tolerance. So allergen immunotherapy, inducing a tolerance state. So there's something, these two terms we should understand, desensitization and sustained unresponsiveness. Desensitization refers to a temporary increase in amount of allergen a patient can tolerate without reacting. A state that is dependent on continuous ongoing administration of allergen. This provides a crucial safety buffer against accidental exposure, but is not considered as a cure. Whereas sustained unresponsiveness, this terminology is very, very important. Sustained unresponsiveness is referred to as remission. It's a more durable state where a patient remains non-reactive to the allergen for a defined period, even after an active therapy has been discontinued. This is more robust than desensitization. So sustained unresponsiveness may still require more level of periodic allergen exposure or maintenance. So I will not go into OIT and epicurence immunotherapy. So what this does is Treg, which will lead to IL-4 and TGF-beta, and suppresses inflammatory dendritic cells, suppression of mucus production, suppression of tissue inflammation, and suppression of effector T cells, suppression of mast cells, and suppression of IgE and induction of IgG4. All it does. So that's a principle. And biologicals. So coming to biologics, the advent of biologics therapies, monoclonal antibodies that target specific molecule in an allergic cascade is revolutionizing the practice of allergic immunotherapy. By temporarily blunting the allergic response, biologics can make a huge difference and make allergic immunotherapy safer and more effective. I'll not go into details of this because of lack of time. So coming to the takeaway messages. So this is a new paradigm. The focus has shifted from strict avoidance to proactive prevention and treatment. Prevention, early and regular introduction of allergic foods in infancy, now proven to prevent allergies. Gut health, a healthy gut microbiome is a master regulator of the immune tolerance and needed to prevent allergies. Precision diagnostic, advanced testing now allow for personalized risk assessment, moving beyond simple sensitization. Modern therapy, immunotherapy, and new biologics drugs are being used to retrain the allergic immune system towards tolerance. The future, personalized medicine will tailor treatment to each patient's unique profile, aiming for a cure. Thank you.
Thank you, sir, for that very informative and excellent overview of the food allergy. We really have come across many conditions in our day-to-day practice in our clinics, in which you have correctly mentioned about the perceived food allergy, which is more common than the true food allergy, which we really encounter. Your description about both the IG and non-IG mediated allergy mechanism in this case is really a great session which you have given us. Thank you. Even about the description about the therapeutic frontiers will help us in knowing about the management options we have. Thank you, sir, for that most lucid information you have given to us. Thank you, sir, once again. Now we'll move on to our next session, which will be on immunology of anaphylaxis by Dr. Dinesh Nayak. Dr. Dinesh Nayak has done his MD Pediatrics from Goa Medical College and has various degrees like MSc PCH with DP Allergy from Gangaram Hospital with gold medalist. He has also done his fellowship in pediatric and adolescent endocrinology. He is presently working in a specialist as in Al Shaq Hospital, UAE, and has wonderful teaching experiences in various medical colleges in Goa and Gulf countries, as well as is a visiting faculty in DPA program. I welcome you, sir, to start the session. Thank you, sir.
Thank you, Dr. Smita. Thanks for generous words, and thank you, Dr. Neeraj and the IIP Allergy chapter for inviting me for this webinar. So let me share my slide. Yes. You all can see, right?
Yes, sir.
So I will be talking about applied immunology of anaphylaxis. So after the two excellent lectures, let's go to the anaphylaxis now. So what we are going to discuss today is about what is anaphylaxis, the different mechanisms, the key cells and their mediators in anaphylaxis. Out of this, the main role of mast cell and the significance of tryptase, and also the role of PAF, the platelet activity factor. Most of these things are well established in clinical practice. Then we will go also to other mediators and other systems involved, which is more of an experimental at present and maybe extrapolated to clinical use later, and the final conclusion. So anaphylaxis is a severe life-threatening systemic reaction causing airway, breathing, or circulatory collapse, usually associated with skin and mucosal changes, and it's caused by rapid release of inflammatory chemicals and from the immune cells like mast cells and basophils. Okay, so this process is triggered by several immunological mechanisms, mainly the IgA-mediated one, then also the IgG-mediated and other non-immunological pathways, and involves a lot of mediators. So the initial classification of human anaphylaxis classified into immunologic, non-immunologic, and idiopathic. So out of that immunologic, most important are the Ig, okay? Then there are other immunological, which is IgG based, and we'll see the different types of it. And non-immunologic, again, the physical factors and certain drugs. Now, there is a fact that this may also involve some amount of immunological basis for the reaction. And finally, the idiopathic, which we'll go again and see in details. Okay, so Ig-mediated anaphylaxis, which is classic and the most frequent mechanism. This is the typical type 1 hypersensitivity reaction, which we see in all common allergies, which we see on the previous two presentations also in allergic asthma, allergic rhinitis, food allergy, wherein the allergen interacts with the allergen-specific Ig and high affinity receptor complex and resulting in the release of mediators. The non-Ig-mediated anaphylaxis, which we have seen in the previous classification, it can be either immunologic or non-immunologic. Immunologic involves complement system, contact coagulation system, and IgG-mediated anaphylaxis. We will see that again in the detail. And the non-immunological will be drugs and certain factors. Idiopathic, that we'll see again. So Ig-mediated, sorry for the repetition, but this is the classic pathway, so it will involve the same steps as in the previous presentation. The first exposure to allergen causes the immune system to produce allergen-specific Ig antibodies. They bind to the high affinity receptors on mast cells, basophils. Re-exposure to the same allergen leads to binding and cross-linking of these Ig antibodies, which signals the degranulation of the main effector cells, the mast cells and basophils, releasing the inflammatory mediators like histamine, tryptase, and other chemicals. And this results into symptoms which are commonly seen as vasodilatation, increased vascular permeability, smooth muscle contraction, and leading to the severe symptoms of anaphylaxis. So this is just a pictorial representation of the same thing what I said, the initial exposure, IgG antibodies binding, repeat exposure, cross-linking, later degranulation, and the symptoms. Okay, so let's see about the non-IgG. Now, non-IgG mediated does not involve IgG, but clinically they are almost indistinguishable from the IgG mediated reactions. That means the symptoms remain same. Okay, so what are the different bases for this? It can be complement system, which I have seen. The complement cascade is the part of the innate immune system and produces inflammatory fragments or anaphylatoxins such as C3A, C4A, and even C5, which are directly activating the mast cells and basophils. IgG antibodies also can form immune complexes with that activate the gamma receptors on the various cells, mainly neutrophils and others, including macrophages, dendritic cells, platelets, basophils, and even mast cells, and causes the trigger mediator release. And direct mast cell activation, like certain substances like medications, opioids, NSAIDs, and some therapeutic antibodies like monoclonal antibodies can directly cause mast cells to degranulate without the involvement of IgG. And the key receptor involved in some of these reactions is the mast-related G protein coupled receptor X2. So this is a nice diagram showing the immunological activation, which involves the Ig, the IgG, and the non-immunological, whether it's the direct activation by certain drugs. There may be the change, genetic change, which comes more in the idiopathic, complement-based, the drugs, PF receptor action, the MRG, the receptor which I just now said, which many drugs like quinolones and NSAIDs can act on, and even certain hormones can act to the hormone receptor. All this finally leading to the degranulation and the symptoms. So just I was saying, besides this immunological and non-immunological type, there is idiopathic type, wherein though rigorous has been identified. Now the range of this idiopathic has been from 6.5% to 35% according to different studies. One of the reasons may be that they have not identified what is the cause, and later studies have shown that certain things may be the basis for this idiopathic cause, like systemic mastocytosis or monoclonal mast cell activation syndrome, which are associated with severe recurrent reactions. And in this, there is a change in the KIT gene, the CKIT gene, which is responsible for the KIT ligand on the mast cell receptor. There is mutation in this. It is usually seen as the D816V mutation, consists of the substrate valine is replaced by aspartate, and this activating mutation results in the ligand independent autophosphorylation of the cell. So also there may be some allergens which were not recognized initially, or they were a little less easy to identify. So examples given like the alpha-gal. Now this is found in mammalian meat, triggers the alpha-gal syndrome, which can lead to severe reactions like after consumption of red meat consumption, or omega-5 gliadin, which is in wheat-dependent excise-induced anaphylaxis, a condition where excise acts like a cofactor that triggers the severe reactions after eating wheat. Or oleosins, like the plant-derived proteins, are underestimated inducers of severe plant-based allergies, such as those to nuts and sesame. So next, now we go to the key players in the immune response. These are the cells and mediators. If you see this slide, these are the things which we already know and which we commonly use clinically. The main cells are mast cells and basophils. These are the primary effector cells in anaphylaxis, which on activation release the massive systemic flood of inflammatory mediators. This is always mainly the mast cells and basophils. The other cells like neutrophils and macrophages play a role in IgG mediated pathway by expressing the F gamma receptors and release the inflammations like PAF, the platelet activating factor. And what are the mediators? Histamine, tryptase, platelet activating factor, and leukotrienes and prostaglandins. These are the common mediators and which causes the clinical effects such as histamine causes increased vascular permeability leading to swelling, vasodilatation causing flushing and drop in blood pressure, smooth muscle contraction, airways and gut. Tryptase, again, important enzyme in anaphylaxis. It causes various symptoms, which we'll see later. Platelet activating factor, again, more important IgG mediated pathway, where increases vascular permeability and bronchoconstriction, also leads to platelet aggregation. And finally, the leukotrienes and prostaglandins. These lipid-derived mediators cause prolonged bronchoconstriction and increased vascular permeability. But if you see, the most important effector cell is the mast cell in IgG mediated or in non-IgG mediated, okay, except in the mast cell independent mechanism. All other anaphylaxis, the mast cell is most important. So let's go in its role. Mature mast cells are primarily found in tissues where external pathogens enter the body, including the skin, GI, and GI tract and airway. And if we do on the microscopic staining of these mast cells, we'll find there are two types. This is based on their protease content. MCT, or the mast cells with tryptase positive but kinase negative. So the mast cells with tryptase, we can say. And other one is MCTC, that will be mast cells with tryptase and kinase. Now, the most important in usual allergy is MCT, found typically at mucosal tissues such as intestine, lung, and nose, and they are T lymphocyte dependent and increasing number in allergic disease. The MCTC does not depend on lymphocytes. It is located primarily in the skin and GI submucosa and accounts for the 99% of the mast cells in the dermis in CSU, chronic spontaneous urticaria. Now, these are usually activated by IG independent mechanisms. Now, whichever mechanism, once this activation of mast cells, they release the mediators. In case of IG dependent one, the IG is bound by the allergen and interacts with the high affinity IG receptor on the surface. In case of IgG, it will be the Fc gamma receptors. Complement will have their own receptors, C3a, C5 receptors, and drugs, as we have seen before, through their mast-related G protein coupled receptor X2. Opioids, neuropeptides, nerve growth factors, stem cell factors, cytokines, all of this can modify mast cell function, survival, maturation, differentiation, growth, even the apoptosis and their degranulation. Now, drugs like fluoroquinolones, icatibant, this is the one which is used for hereditary angioedema. General anesthetics such as atricurone, rocuronum, tubicaron activate mast cells through this MRGPRX2, and this is independent of the IG pathway. Now, what happens in this pathway is that binding of these drugs, or the drugs which express this tetrahydroisoquinolone motif, directly binds to this receptor, resulting in protein kinase and phosphatidylate 3 kinase pathway activation, calcium release, and degranulation. The importance of this receptor is that besides in anaphylaxis, in case of CSU also, chronic spontaneous urticaria, this is the activation of this mast cells through this results into neurogenic inflammation, pain, itch, and pruritic skin disease. So if we see this diagram, this is the mast cell, and it is being triggered by different mechanisms. The most common being the IG mediated, and there is complement mediated, the C3 and C5 receptors, the IgG, idiopathic, where there is the receptor is unknown, and there are certain drugs to MRGPRX2 or physical factors, okay, like exposure to cold, UV radiation, exercise, even alcohol, and all these things. And finally, all this lead to degranulation, resulting in the release of the mediators like histamine, tryptase, BF, causing the various symptoms. So besides mast cells, the other cells which are important are, now this is, as I told you, all this thing initially, whatever we know has already been clinically used. Basophils again are important as mast cells, and they have high levels of high affinity IG receptor and also activates IG receptor gamma, causing through the release of the most of the active mediators. Now, IG dependent activation, as Dr. Guraj has just now mentioned, of immunology is associated with the elevations in the level of certain basophil cell separate markers such as CD203C or CD663, just as we saw in the previous presentation. And this forms a base of basophil activation test, which can be used to diagnose or confirm allergen sensitization and to monitor the effects of immunotherapy. The other cells like monocytes and macrophages again express high levels of activating Fc gamma receptors, and they respond to anaphylatoxins. They will also release endothelin 1, which we'll see later. Neutrophils, again, are very important cells in anaphylaxis, but mainly in IgG type. They express severe activating Fc gamma receptors, can produce histamine, and can release platelet activating factor in response to stimulation of the immune complexes. Particularly in some patients with asthma, they express this Fc epsilon receptors and have the effect of the same effect like Ig asthma. So the major enzyme stored in neutrophils is myeloperoxidase, MPO. This levels are increased in patients with anaphylaxis, and the research has shown that antibody-mediated neutrophil depletion can reduce anaphylaxis in IgG-mediated passive systemic anaphylaxis and mast cell-independent active systemic anaphylaxis. When I say passive, it is the one which is done in experimental cases like in mice and all, and whereas active systemic anaphylaxis which is seen in vivo. Again, the other cells which are also responsible, which are being studied now, not that used in practical purpose right now, are platelets. They release mediators such as platelet activating factor 4 and serotonin, and they contribute to the pathophysiology of the anaphylaxis. Platelets can express Fc epsilon receptor 1, 2, and Fc gamma receptor 2A, and they can be activated ex vivo following incubation. with serum from allergic patients and subsequent exposure to relevant allergen. So again, the basophils can form association with platelets, and this interaction also needs further investigation in context of anaphylaxis. So this again forms a basis for further research. So from the cells, let's go to the mediators. The mediators help us in diagnosis, and these are the mediators which are responsible for most of the signs and symptoms. No single lab test can make the diagnosis of anaphylaxis. What is commonly used is histamine and serum tryptase. They can help to confirm the diagnosis, but neither is specific for anaphylaxis, so results must be interpreted in clinical context. Research is regarding more sensitive and specific tests to confirm the diagnosis of anaphylaxis underway. And because of our recent understanding of the signaling pathways, a lot of new molecular markers have acted as for the candidates for diagnosis and as a therapeutic target too. A robust knowledge of the plethora of anaphylactic phenotypes and endotypes would lead to identification characteristics of better diagnostic and predictive biomarkers that would in turn improve the clinical management of patients and their quality of life. So if you see this slide, these are the different cells like mast cells, basophils, neutrophils, monocytes, all, and there are different. These are the different mediators on the left side. We'll go through the important ones. First, the histamine. It's a diamine prestored in the granules of mast cells and basophils. Once released, they act to the H1 to H4 receptors, causes multiple intracellular signaling, and leads to vasodilation, increased permeability, and bronchoconstriction. The sampling for histamine is again crucial because the sample should be drawn with a wide bore needle and should be kept cold and processed promptly. This histamine rises early, 5 to 15 minutes, normalizes quickly, and ideally measured within 30 to 60 minutes after the onset of symptoms. This is again the crucial period. Initially, 30 to 60 minutes, everyone will be busy in managing the anaphylaxis. So again, the half-life of histamine is only 2 minutes. Now, the certain studies may show 20 seconds to 20 minutes, depending on the site of action where they have tested it, and it is falsely elevated in cell injury. That is example in hemolysis. Now, because of this short half-life, stable histamine metabolites like N-methylhistamine are often measured in urine to access the histamine release retrospectively. This again for aiding the diagnosis later. The tryptase, again, the most important enzyme, which is released by mast cells and to a lesser extent by basophils. Total tryptase concentration does not always increase in anaphylaxis, but is always elevated in severe allergic reactions compared with the mild reactions. So this is again a clinical pointer towards increased tryptase. Tryptase have been described to have 4 types: alpha, beta, gamma, and delta. But out of this, the active forms of alpha and beta and the pro-beta tryptase. This is again more important clinically for us. That's why it's said that best marker is the rise in concentration of beta tryptase in the peripheral circulation instead of total tryptase. Like, because unlike the alpha tryptase, which is released by mast cells only during the activation and constantly that time, the beta tryptase is already stored in mast cells and released after IgE dependent activation. So this helps the basic level of beta tryptase also helps in further confirmation of the diagnosis. So what happens during anaphylaxis? Tryptase can be detected in serum 30 minutes. So we can see initially it's histamine in 15 minutes. By 30 minutes, the tryptase enters the blood circulation, and after the onset of symptoms, peaks within 60 to 90 minutes and starts beginning to decline after 2 hours. Returns to normal levels within 24 to 48 hours. So for tryptase blood sampling, it should be collected within 1 to 4 hours of the reaction. And maybe another blood sample can be collected after around 24 to 48 hours to get the basic level of basal level of tryptase. Unless it's a recurrent anaphylaxis where we already have a basal level, then this may not be required. Now, how are they detected? The immunoassays usually are done to detect both the total, which includes the baseline release, and the mature, which are released only at the time of activation tryptase. One of the corollaries in mastocytosis, the baseline levels of pro-beta tryptase and predominantly alpha tryptase are elevated. Now, this both being already elevated indicates more of an increase in mast cell mass in mastocytosis rather than the sudden activation. Okay, so what's the level? Now, in general, it is accepted like baseline tryptase levels above 8 ng per ml are considered elevated, but this is not always a sign of mast cell activation because it is difficult to establish a cutoff as there are no special levels to confirm mast cell activation and hence the anaphylactic episodes. So what do we do instead of taking a just baseline is use a formula 1.2 multiplied by the baseline plus 2 nanogram per ml. Okay, so this helps to get us further diagnosis, helps in diagnosis of anaphylaxis. Levels are typically higher and more persistently elevated in anaphylactic reactions to IV drugs and insect venom compared to the food anaphylaxis. Now, this may be because slower onset and more sustained duration of symptoms, more localized mast cell degranulation and activation of basophils, and less tryptase in the mucosal mast cells. So what are the other enzymes besides tryptase? We know that carboxypeptidase A, again, it's a metalloprotein, which is zinc dependent, found in basophils. It's elevated in anaphylaxis and drug-induced reactions, but the levels do not correlate with tryptase. So we don't know how useful it can be clinically. Kinase, this is another serine proteinase which activates the renin-angiotensin system, which we know is the main homeostatic regulator of the blood pressure, and its activity is heparin dependent. It's elevated in anaphylaxis up to 24 hours after onset of reaction. So this gives a long period of time, and its values correlate with the tryptase. So this can be a good biomarker. Elastase, another serine protease released mainly by neutrophils, although it may also be present in granules of basophils and mast cells. It cleaves the kinin light chain, activating the contact system, which we will see later how that's involved in anaphylaxis. And myeloperoxidase, just now we saw that's the enzyme from neutrophils. The DNA myeloperoxidase complexes, along with elastase enzyme, these are increased in anaphylaxis and also increases with the severity of episodes. So this again can be used for confirmation of the anaphylaxis and its severity. So besides the enzymes, the bioactive lipids, the most important one being platelet activating 4, is important in immune function and vascular biology. They play a significant role in allergy and anaphylaxis, and they act as a complementary biomarker for tryptase. So PAF is implicated in platelet aggregation, various immune and inflammatory responses, and it can also activate human mast cells. So the human mast cells, which are the human lung mast cells, as well as the mast cells from peripheral blood, that is human peripheral blood derived mast cells, release histamine and prostaglandin D2 rapidly in response to PAF. The other PAF producing cells like platelets, neutrophils, and macrophages can also respond to PAF. They signal through the G-alpha inhibitory protein, activating the lipids, phospholipases, and enhances Ig-dependent mediator release. PAF also releases certain chemokines like interleukin 8 and also upregulates mRNA expression of other chemokines. And even cytokines, it induces the release of several cytokines and participates in bronchoconstriction, hypertension, and endothelial permeability. So its elevation is associated with all these hemodynamic changes. And it has, that's why been proposed as a potential therapeutic target, because it is seen in increased right ventricular pressure, total pulmonary resistance. The PAF may be responsible for that. And in mouse models, they found out that combined inhibition of histamine and PAF almost entirely blocked anaphylaxis. So this may suggest again additive or synergistic effect of histamine and PAF. So PAF increases the severity, and higher percentage of patients were diagnosed based on PAF rather than histamine tryptase in some of the studies. It's widely evaluated mediator as biomarker, but although it has not been extrapolated to the clinical practice due to again its short half-life. And that's mainly because it's rapidly inactivated by the enzyme. Mainly the enzyme is PAF acetyl hydrolase. This has been again proposed as a possible molecular marker for anaphylaxis because its levels drop during the reaction. The other bioactive lipids are like sphingosine 1 phosphate, arachidonic acid derived lipid molecules such as the prostaglandins, PGD2 prostaglandin, leukotrienes, and thromboxanes. These again have been studied for the because this prostaglandin leukotriene study is mainly through mast cell activation are considered valuable biomarkers in anaphylaxis. And one of the correlates for that, NSAIDs have been associated with increased PGD2 and production of overexpression of adenosine receptor 3. Among cytokines, again, these are the cells mainly involved in the immune system, play a key role in the inflammatory process. In anaphylaxis, mainly the TNF alpha, this is a cytokine which is increased along with its receptors also, TNF receptor 1, and can play a crucial role in alteration in the vascular permeability. Another cytokine which is released, TGF beta, it has an inhibitory effect on this TNF alpha. So this again may be beneficial for us in treatment. Gamma interferon which plays a key role in Th1 response is secreted by the peripheral blood mononuclear cells during anaphylaxis. GM-CSF has been studied because seen in some anaphylactic reaction, but it is found to be more of a trigger rather than a mediator. And platelet factor 4, which is released by platelets following the activation of Powell system, its levels again has been seen to increase in certain anaphylactic models in rabbits. Then besides the cytokines, the chemokines, mainly two are seen, CCL2, which also called as monocyte chemoattractant protein, was increased in mice models and human anaphylactic samples. And one of the studies done in pediatric patients, along with this CCL2, another chemokine CCL11 was increased. So this may have a role in diagnosis. Then the interleukins, we have seen in the previous presentation also interleukin 2, 4, 5, 6, 10, 13 are increasing severe anaphylaxis. And out of this, the 2, 6, and 10 totally correlate with the severity of episodes and also with histamine concentration and hypertension. IL-6 is released within the first few hours and after allergen exposure, and high levels is seen in hypersensitive reactions and nervous induced by monoclonal antibodies as well as in peri-op patients. Now, the other systems which are involved in anaphylaxis, again, more for a research purpose, we need to know this. Complement system, cognition system, and the contact system, and the fibrinol system. All three are interrelated with each other when the anaphylaxis is involved. Complement system usually activated through the classical pathway, releases C3A, C4, and C5, and these are responsible for binding with the mast cell through specific G protein receptors and basophils, leading to degranulation and the symptoms. Anaphylactoxins alone can also trigger anaphylactic reaction. Now, this is a busy slide which indeed shows us the interrelation between the complement system, cognition system, fibrinolytic system, and the activation of the fibroblasts. So, what is the actual relation? Heparin released in anaphylaxis results in activation of the contact system, and after the degranulation of mast cell basophils, this binds the high molecular weight kininogen and to factor 12 of the contact system, resulting in autoactivation of factor 12 and initiates the cascade. Factor 12 transforms precalcitonin to kallikrein, which hydrolyzes the high molecular kininogen to bradykinin, again, which is a vasoactive mediator. And in the insect sting anaphylaxis study, it was shown that certain factor 5, factor 8, and fibrinogen were decreased, whereas other studies have shown that decreased levels of F2, precalcitonin, HK, as well as elevated bradykinin in anaphylactic patients, again, more for research purpose. In cardiovascular system, we've seen that in anaphylaxis, there is increased vascular permeability, vasodilation, and there is constriction of vessels in thoracic cavity. Or existing cardiovascular disease increase the risk of severe anaphylaxis, and even the activated heart mast cells can release mediators in the thoracic cavity. One of the hypersensitivity syndrome, coronary hypertension syndrome, called Coolidge syndrome, is characterized by massive activation of the cardiac mast cells and characterized by acute myocardial damage, which is seen to release a lot of troponin, and that can be identified. The blood vessels or the endothelial cells in the vascular smooth muscle cells are responsible for this vasoconstriction and bronchial dilatation. In anaphylaxis, especially during the shock, muscle releases vascular endothelial growth factor that increases the vascular permeability. Endothelin-1, which again is secreted by the blood vessels, also by monocytes and macrophages, are responsible for various severe symptoms. These endothelial cells act as both receptors and effector cells, and they are mainly releasing this nitric oxide, which we know is an important vasodilator. Histamine and PAF induces the synthesis of NO by activating the endothelial NO synthase. And all this NO which is released causes a lot of vasodilatation, hypotension in anaphylaxis. And in case of anaphylaxis, the respiratory symptoms, FeNO or fractional exhaled NO can be used as for diagnosis. Let's go to the last two systems. The nervous system. Nervous system, we know histamine acting to different nerve fibers. Tryptase, again, releasing activated protease activated receptor 2 or sensory neurons, stimulating the release of substance P and calcinogene-related peptide. Serotonin is being found to cause a lot of symptoms in IgE-mediated anaphylaxis. And adenosine, which is released by the nervous system, also produces all the vascular symptoms, and this can be released from the stimulated mast cells. So nervous system and immunology, they may be related to each other. Immune cells are activated through neurotransmitters, and molecules released through the activation can also increase the neuronal activity. But one more thing which we need to know about the nervous system is that it may have a role in recovery in anaphylaxis, like epinephrine, norepinephrine, angiotensin 2, which are all vasoconstrictors, and they help to compensate for the vasodilatory effect of most of the mediators. And there was one interesting study done where they found that glutamatergic receptor mGlur-R7, this was the receptor here, if that is present, it acts as an auto-inhibition of the anaphylaxis, resulting in a normal reaction to an allergic event. Instead of in its absence, it causes severe anaphylaxis. So this is again an interesting study, and further research is needed in this. Besides the nervous system, the blood circulating biomarkers, because they're easy to identify, they are also being studied, like circulating proteins, apolipoproteins, or even hemoglobin B subunit. They have been found to increase in anaphylaxis, and they can be used as biomarkers. One more blood-derived circulating biomarker is microRNAs. Again, not used in clinical practice, but has more experimental use. And because one of the study in pediatric population with food-induced anaphylaxis, they showed increased circulating serum levels of microRNA 21-3P and 487B3P. And in case of adult samples, they found another microRNA 451 has increased. The metabolites which had been earlier also, histamine, instead of histamine, we could measure the N-methylhistamine. There's another N-methyl limidazole octane. This can be detected in urine 24 hours after the onset of reaction. Now, again, it has limited sensitivity and specificity, but again has a role. Another protein is 9-alpha 11 beta PGF2, seen as a lipid-derived biomarker of anaphylaxis, and given its stability in both urine serum, it can be used as a biomarker. Also, these common molecules like glucose, lipids, cortisol, beta, and oleamide, they are also found to be, depending on the triggers of serotonin production, these molecules also increase. Now, having all this knowledge, we also should understand that all this don't work independently, but they work in particular microenvironments like skin, lung, intestine, heart, vascular system, and nervous system. And study of this can considerably improve the clinical practice and identification of better molecular markers. Now, one last slide. Can this anaphylaxis be beneficial? Now, my studies have shown that certain type 2 immune response in honey bee venom, that BV, would increase the survival of mice if challenged with the whole bee venom. And one of the major bee venom, the bee venom PLA2, when a near lethal dose was given, a type 2 immune response reduced the drop in body temperature induced by this BVPLA2. This is commonly seen in humans, but this study was done in mice. Now, these effects were dependent on Ig and high affinity receptor. All these Ig high affinity and mast cells could enhance the survival of mice injected with Russell's viper venom. Now, the mechanisms involved could be the proteolytic reduction of this toxicity of venom by the mast cell derived enzymes like carboxypeptidase or protease 4, that's kinase. And in such settings, anaphylaxis could actually be beneficial, wherein it could prevent death by envenomation, hoping that individual survives the anaphylaxis first. So it is speculated that anaphylaxis could be a small, most extreme or maladaptive end of the overall spectrum of Ig-mediated immune response, and which is usually developed to enhance the resistance to such venoms. So final conclusion, mast cells and basophils are the primary effector cells in anaphylaxis. Plasma histamine level or serum tryptase level can help confirm the diagnosis, but neither is specific or specific test for anaphylaxis. So that's why various molecules have been identified and proposed as biomarkers in anaphylaxis, but none of them till now have been extrapolated to clinical practice because of lack of further studies which can connect the clinical manifestation with the underlying molecular mechanisms. Therefore, a more further robust knowledge and plethora of anaphylactic phenotypes and endotypes would further help us in identification and characterization of better diagnostic and predictive biomarkers that would in turn improve the clinical management of patients and the quality of life. And finally, although potential evolutionary benefit of anaphylaxis remains uncertain, this recent evidence in mice suggests that anaphylaxis may have effects that can reduce the toxic effects of certain arthropod or reptile venoms. Thank you.
Thank you, sir, for that beautiful elaboration of the immunological basis of anaphylaxis. The way you elaborated the immunological pathway and also taking on the details of the smallest all molecules involved in the anaphylaxis, even about the recent updates about the biomarkers available, the various tests beyond doing just the serum tryptase. It was really a wonderful session, sir. Thank you, sir. Now I'll go forward to the next session. It will be a session about most awaited, that is the immunological basis of immunotherapy, which will be taken by Dr. Kunal Chadwa. Dr. Kunal Chadwa is a DM in clinical immunology and rheumatology and with a gold medalist. He has various fellowships to his account, including SL Euro Lupus Fellowship at UCLH London with Euler Appler Exchange Fellow, to name some. He has done multiple Euler courses with specialized training in allergy and clinical immunology, has multiple awards, in which includes the winner of People's Choice Award, even Best Research Paper Award in Indian Journal of Rheumatology 2024. He has more than 40 research papers in various journals. Welcome, sir, and take the session forward, sir. Thanks.
Thank you so much. Am I audible? Am I audible? Yes, okay.
Yes, sir, you are audible.
Oh, okay. So, a very good evening to everyone. And I am between your sleep and the presentation. And usually, immunology is the sleepy subject. So, I'll try to make it as interesting as possible. And I'll be talking about the immunology of allergen immunotherapy. How can we reprogram the allergic response? And for betterment of understanding, I've tried to keep the presentation as simplistic as possible. So what are we going to do? The first slide in itself tells us that when an allergic reaction is happening, your T cells and mast cells are very angry. They're ready to blast off. And with immunotherapy, either whichever way you go about, we have a much more calmer mast cell, a much more calmer T cell, in our system. So our agenda today would be talking about how we can understand and a small introduction of what allergen immunotherapy is, what are the core mechanisms of allergen immunotherapy from T cells to B cells to the mast cells and basophils, what are the routes of administration, so comparing how skit, slit and other deliveries are different, what are the newer advances in management, and what are the key unanswered questions, and a small conclusion that we can follow it forward. So, to give you a very brief introduction of what allergy is and what happens in the pathogenesis is, you have your Th2 system that is primarily designed to cause decrease inflammation, that is inhibit the Th1 kind of inflammation and attack helminths. But it is a case of mistaken identity where the Th2 system, like this guy, is more interested in the allergen as compared to the helminth itself and starts attacking it, causing a significant immune response. So a dust mite might cause a significant amount of fire where dust mite was actually nothing. And we have had our experts telling you what happens in case of most Th2 inflammatory disorders during the course of this conference or conclave today. So a small introduction. What is allergen immunotherapy? It involves repeated exposure of an allergic individual to a particular allergen in order to retain the allergen in the immune system. The objective is to transition the immune system from hypersensitivity to tolerance. And the advantage is that AIT is still the only sole therapy that is disease modifying and hence is capable of altering our natural progression of allergic disease. So if you have a child who is to be set on an allergic march and instead you give them the allergen immunotherapy at the right point of time, you will realize that this has been able to alter the natural system of his uh, allergies. So an overview of the core mechanisms of AIT. So it has three basic mechanisms. You would have in your immune system two parts. You would have your innate immune system and you would have your adaptive immune system. So the allergen immunotherapy also concentrates on both the adaptive and the innate immune system. But because an adaptive immune system has greater role to play from starting with the allergen presentation to processing the allergen and then leading to the allergy cascade, you would have greater importance of the adaptive immune system, specifically the T cells. Those are the master regulators. They decide whether the T cell is going to become a Th2 type, a Th1 type, or a T regulatory cell. And hence, cell re education is very important. So is B cell remodeling. You then start producing remodeling antibodies that are much more resistant to stimulation by an allergen and causing an allergic reaction. And you even have the effector cell silencing. So you would have mechanisms that would cause desensitization of both the mast cells and basophils. So it is not just at one specific area that the allergen immunotherapy acts at, it acts at multiple levels. And there is an entire semiology that it brings about. So the first part is the part that we have discussed in great depth today, from Th2 to food to anaphylaxis. You would have an allergen that would be presented. This would be taken up by your dendritic cells. These dendritic, let me just see if I can point it out. Yeah. So these dendritic cells will then, in the influence of the innate lymphocyte cells type 2, would then interact with the T cells and then decide whether this T cell will become a Th2 cell, whether this will become a follicular type 2 cell or a T2A cell. Th2A cell is a very important cell that we'll see the importance later on. And then this will stimulate the B cells to start producing IgE. These IgE will have both somatic hypermutation and affinity maturation to bind to an allergen very strongly. And once it comes in contact with that allergen, this will then bind to those mast cells and basophils and cause degranulation. This degranulation will in turn lead to release of all these chemicals that finally lead to allergic symptoms. Now, this has been going on and this is causing damage to the body. The patient has come to an allergist and the allergist has identified that this is the most likely allergen that is causing his problem. So what the allergist will do, he will explain the patient that you probably need immunotherapy and he will start the patient on immunotherapy. So what happens when you start them? You start them and then you try to turn the dendritic cells into regulatory dendritic cells, and these will then start releasing anti-inflammatory cytokines like IL-10 and TGF-beta, and this will in turn shift the T cell uh, uh, phenotype into a more regulatory phenotype with T regulatory cells and TR1 cells and T regulatory TGF-beta producing cells. This will in turn lead to production of B regulatory cells also, and these B cells will produce different kind of antibodies against the Ig that were getting produced, and all of this will in turn have negative regulatory effect on the already carrying on allergic phenomenon. So what is your T cell? So T cell education or the centrality of T regulatory cells are very important because T regulatory cells are at the heart of, they're the most important cells that are involved in case of uh, allergen immunotherapy. And what they primarily do, so to give you a better example, the T regulatory cells are like your the main principle of your colleges, and they are there to ensure that discipline is regained. If the Th2 cells are becoming overactive, they'll come and tell that you have to establish the parampara, the pratishtha, and the anushasan of the immune system, and you will have to bring back the regulatory framework and bring back cool down the inflammation, bring the fire down, and ensure that there is peace again. So there are two major kinds of T cell phenotypes. There is the FOX3 positive T regulatory cell. These are inducible T regulatory cells and are defined by the master transcription factor FOXP3, which is essential for their development and suppressive function. And you also have the type 1 regulatory cells. These are cells that are potent suppressor of both Th1 and Th2 response, and they are characterized by high level of production of IL-10 and lack of FOXP3 suppression. They are even present innately there, and on chronic stimulation they will start producing their action. So what all functions do T regulatory cells do? And like Yoda, they come to argue predominantly for peace, and they act by causing cytokine deprivation. So they have very high affinity CD25 receptors, and CD25 is actually a receptor for IL-2. IL-2 is a cytokine that, when present, is a growth factor for most T cells. But since T regulatory cells have very high affinity receptors, they will actually suck out all the IL-2 that is there in the microenvironment, and hence the actual T cells which don't have as high affinity CD25 receptors don't get enough IL-2, and then they'll die off. So the T cells that are causing problem are deprived of their oxygen of their IL-2 by the T regulatory cells. At the same time, it causes release of two cytokines. The very important cytokines are TGF beta and IL-10, and this in turn also inhibits the cytokine functions of the functions of the effector T cells. So the Th1 or Th2 T cells won't be able to function like the way they wanted. They also cause down modulation of the dendritic cells. So the dendritic cells that were now very actively presenting antigens or allergens from the outside environment are not doing so as effectively. They also cause metabolic pathway alteration and in turn release more amount of adenosine. So if you go back to your pharmacology days, there are drugs like methotrexate and leflunomide and sulfasalazine, and all of these DMARDs finally what they lead to is increased amount of adenosine, and this adenosine is actually a lot immunosuppressive in action, and hence the T regulatory cells cause alteration in these metabolic factors. They also increase the amount of soluble IL-2 receptors and cause further activation of T cell action through epigenetic mechanisms. Now, there are two important cytokines that are there. It is the IL-10 and the TGF beta, and they act often in tandem. So what interleukin 2 is almost the master cytokine of all T regulatory functions. It inhibits the Th2 cells, suppresses the IgE production, promotes the class switch from IgE to IgG4, and directly raises the activation threshold for mast cells and basophils. Whereas TGF beta works along with IL-10 to establish a comprehensive regulatory environment. It is also very crucial in healing. So whatever damage has been done by the inflammation of Th1, Th2 pathways is often healed and regulated by the TGF beta pathway, and it promotes secretion of IgA at mucosal surfaces. Then comes the role of the IL-10 TGF beta. So how does it act upon? It acts on the dendritic cells to make them more tolerogenic. They act like your Js and Virus in tandem to ensure that the anti-inflammatory mechanism is well maintained. They act at multiple levels. They cause energy to T cells. They cause increase in the amount of regulatory FOX3 positive T cells, further increase in the amount of regulatory TR1 T cells, increase and reprogramming of memory T cells, reduce the function of effector T cells, and also change the kind of memory T cells that are already there. So they bring a lot of smoothness and calmness to the environment of allergies that are there. Along with this, there is also epigenetic reprogramming that happens with T cell exhaustion. So a shift towards tolerance is cemented even at the genetic level. And this is one of the more important causes why you see long-term effects with allergen immunotherapy. It is not just that till the time you're giving allergen immunotherapy, the effects last. Beyond that time also they are lasting because epigenetic reprogramming happens. So what happens here? The GATA3 gene, which is the Th2 master regulator, becomes hypermethylated, silencing the Th2 program, and the FOXP3 gene becomes hypomethylated. Uh, uh, and this in turn starts acting as the major cytokine. So you have more regulatory cells as compared to less inflammatory cells that bring about. And chronic antigenic stimulation also leads to the function of inactivation of the remaining effector cells. So if you have long-term chronic stimulation, the T cell exhaustion happens, and this is characterized by upregulation of inhibitory immune checkpoint receptors like PD1 and CTLA4 on the Th2 cells, which deliver a powerful off signal. So you will have more CTLA4 and more PD1 receptors on the cells on the T cells, which have more anti-inflammatory or inhibitory function and are much more difficult to activate on allergen exposure. Now the B cells regulatory function. So same as there are T cells, there are B cells also. There is profound change in the T cell compartment that mirrors the B cell changes also. Like T cells, you also have B regulatory cells here that produce IL-10 and contribute to overall immunosuppression in the milieu. They act as the major drivers for change of immunoglobulin class switch from IgE to IgG4, and the antibody switch is actually a cardinal feature of the successful AIT. How do you test whether your allergen immunotherapy is getting successful? You see if actually the allergen specific Ig is reducing with time, it is steadily declining, and whether your IgG4 antibodies or IgG1 antibodies are rising with time. So in here, all of this, IgG4 has a very important role. The allergen specific IgG4 is often a quintessential biomarker of effective allergen immunotherapy, and it has multiple effects. So if you actually see, an IgG4 has actually two arms, but both these arms can actually freely move about and then merge again. So what happens is there is actually a functional monovalency of this IgG4 antibody, and they have very high affinity to a given allergen. So what this does is, because with each IgG you have two arms, both of them bind, and this increases the allergen binding strength and such lattices form. So because of these lattices being found with both arms that are there, you get an antigen antibody complex that is inflammatory in reaction. But with IgG4, because you have different arms on each side and there is functional monovalency, these arms don't form. And hence, the cross-linking of antigen and immune complex formation does not happen. Say, at the same time, they have very weak Fc receptors, so they don't cause complement-mediated lysis. They also have very weak binding to the Fc gamma receptors, and hence they don't cause phagocytosis along with weak complement binding. They engage very strongly with the inhibitory receptors on the mast cells and cause a powerful off signal. They inhibit the IgE mediated so it is the same antigen that will compete between being bound to the IgE and the IgG4. Since the IgG4 monoarm is much freely floating, it will first bind to the allergen and it won't allow the allergen binding to the IgE, and it prevents the forward loop that starts once an IgE binds to the Th2 cells and causes a positive reaction arm. And the Fab exchange arm is inherently anti-inflammatory, as we did saw in this figure. So what happens, and what I often tell is, what happens when when there is a bee sting, you have an IgE that will be produced against a bee sting along with an IgG1 that is initially performed. And when you have this thing again, you will have those hypersensitivity reaction. But on repeated exposure to venoms, you will start then producing the inflammatory cytokines, anti-inflammatory cytokines like IL-10, and then there is a class switching. So because there is a class switching, all of these effects that the IgG4 will then bind to the venom antigen, this is much less immunogenic and much more anti-inflammatory, and hence with time the reaction disappears. So if all of you have seen this beautiful movie called Kabhi Khushi Gum, Kabhi Gum, there is a song where our IgE was dancing very well with the allergen. The T regulatory cell or the B regulatory cell came and it told that bus you have danced enough, now it is your time to go. And then the IgG4 cells come, they bring about anti-inflammation and bind to the allergen very strongly. So both the IgG1 and the IgG4 are very important. In the initial phases or the early phases of the immunotherapy, it is more IgG1 that is the dominant blocking antibody rising quickly to provide initial protection. Whereas in the late phases, it is more IgG4 that rises slowly and causes long-term durable tolerance. And we'll see how this goes about. Also, the earliest manifestation is by the effector cell silencing. So once you start your rush immunotherapy, it does take time for the IgG4 or the IgG1 to form. So how does that rush immunotherapy causes tolerance against an allergen or again through allergen immunotherapy? It is through the desensitization of these effector cells called as mast cells and basophils. This is caused by an increase in the activation threshold of these cells that will progressively require higher concentration of an allergen to trigger degranulation. And we will go, there are certain changes in the cytoskeleton with chronic exposure of an allergen on the mast cells that makes it difficult for the cascade that starts once an IgE binds to the allergen on mast cell, and hence it is much more difficult for a mast cell to degranulate on chronic early exposure. So the semiology. So as soon as you start desensitization, an intrinsic change happens within the effector cells. They are able, there is a stable reorganization of the actin cytoskeleton, which uncouples the IgE signaling cascade from calcium mobilization that is required for degranulation, and hence degranulation does not happen. There is marked decrease in mast cells and basophil reactivities, and a significantly higher concentration of allergen is needed to trigger these mediator release. This provides rapid, a bit transient protection. This is transient. If you are not going to continue with your immunotherapy, this will go away. In later weeks to months, what happens is you go from more shift from a active regulation to a more regulatory phase with starting of blocking antibodies. The predominant blocking antibody here is IgG1. IgG1 is easier to produce as compared to an IgG4, and hence this is the first antibody to be produced. It does not have anti-inflammatory action, but what it does is it does the blocking very well. So it won't allow the allergens to bind to the IgE molecules, and hence in turn you would have lesser allergen that is exposed to the IgE, and more allergens would bound to the IgG1 allergen. And this is the same reason why between weeks to months the patient will begin to experience a noticeable and progressive clinical improvement in symptoms. In late phases is where all of these things will again start from months to years. So you start now producing more IgG4 antibodies that becomes a dominant blocking antibody. A gradual but steady decline in the allergen specific IgE starts, and you have epigenetically fixed changes in the regulatory T cells and B cells that I did talk about. Your FOXP3 becomes hypomethylated, your GATA 2 becomes hypermethylated, and this phase is responsible for long-term disease modifying effects of AIT with clinical benefits that can persist for years even after the treatment is discontinued. Your memory cells also now B memory cells and plasma cells also now become IgG4 producing. So this is what we did talk about, whether you're giving SCIT, SLIT or intra-lymphatic immunotherapy, your these dendritic cells now become much more tolerogenic. They release a lot of IL-10 and TGF beta. Both T regulatory cells and B regulatory cells start functioning. Your immunoglobulin production shifts from an IgE production to a IgA1 or A2 in case of mucosal immunity, both at gut and at respiratory epithelium. You start producing more IgG4 antibodies, and hence the process of immunotherapy is effective. Now we have about 4 different modes of immunotherapy that have had some significance, and whether it is subcutaneous, sublingual, or tablets that we have now with Sensimune, oral ingestion or direct intra lymphatic presentation. You have different cells that are there. So for subcutaneous, you would have more dermal dendritic cells and Langerhans cell. There are different cells if there you have the slit. There are intestinal dendritic cells if you have the oral immunotherapy. And because you are injecting directly into the lymph nodes, you require actually very low doses of allergens because it will be directly taken up there. The OIT actually requires very high levels of cumulative doses. Slit again requires high cumulative doses. Skit will require a little less than what slit does, and the treatment duration usually is much longer for both skit and slit. For intralymphatic, it is slightly lesser, but we still have a lot of inexperience regarding the intralymphatic injections for immunotherapy. It hasn't come to the clinical practice as probably it should have, and oral immunotherapy is much longer. The shifts here again will be predominantly IgE to IgG4. They'll because both sublingual and OIT also have a mucosal component, you would have again a IgA component that can bring about. The more invasive it is, the higher chances of adverse events. So with both SCIT and oral immunotherapy, you might have some adverse risks. SLIT is again very safe, and because there are no mast cells in lymph nodes, your intralymphatic immunotherapy is actually much more safer. Now, we are still in search of the perfect biomarkers, but probably the ratio between the specific IgE and the specific IgG4 will give you a good indication. An IgE facilitated allergen binding is a functional assay that tests what is the degree of IgE that is functionally binding. This can be a marker of efficacy of immunotherapy also. So is a basophil activation test. And what we have over the years realized is there is a specific Th2 cell that is called as the Th2A cell that progressively reduces when you give immunotherapy. This has been proven with beautiful studies in peanut oral immunotherapy, and we find that this progressively reduces very effectively once you start immunotherapy in these set of patients. The innovation. So, why do we want innovations? We currently find that there is a lot of allergenicity along with immunogenicity in our immunotherapy reagents, and we'd want a lot of immunogenicity in them, but as less allergenicity, so that there are much less side effects. So, adjuvants are used in vaccines to increase their immunogenicity, and the same thing we are trying to do with immunotherapy also, that so that there is slower release of allergens. But sometimes they haven't given us that greater response. We've even been trying a toll-like receptor agonist that can skew the response to a more T regulatory phenotype as compared to a direct allergen exposure. You have newer allergoids that were there present in India intermittently but have gone out because probably they didn't get the same kind of commercial response they were expecting. But these are chemically modified extracts to reduce the IgE conformational epitopes, whereas preserving the T cell epitope. So these won't cause any allergic reaction, but they will cause an immunological reaction, in turn causing tolerance. You can even are genetically engineering the allergens and producing only proteins that bind to an intact T cell epitope without significant binding to the IgE, and you are just synthesizing the T cell epitope through peptide synthesization, and this will have much less allergic exposure, and in turn much less of side effects. Passive immunotherapy. So we have had two cases, one with peanut and the other, sorry, one with cat and the other with birch pollen in the European trials, where they have designed IgG4, specific IgG4s, again, both peanut and, both birch pollen and cat, and given it to patients who had very severe allergic manifestations. And hence, this caused them long-term immunotherapy suppression, and gave them significant amount of benefit. This would again, because these are more difficult to produce and procure, would be very costly. And the other newer strategy that I think we are using in India is the combination of allergen immunotherapy with a monoclonal antibody. So we do use a combination of omalizumab and starting immunotherapy in patients who have very severe allergies, whom you want to control their symptoms and give them disease modifying therapy. So you would start them on omalizumab and then start them on immunotherapy so that their reactivity is significantly reduced. So this is what we did try talk about. We have subcutaneous injections that could be standard extracts that we use very commonly, extracts along with monoclonal antibodies, extract along with TLR agonist. You have recombinant allergens with allergoids, and you have passive immunotherapy that we have used in case of cat and birch pollen. And you could have extract immunotherapy for food allergies or sublingual immunotherapy that are already there. We still have a few unanswered questions. So, what is the nature of long-term tolerance? What is the precise cellular and molecular nature of the immunological memory? And how long will it maintain even after cessation is still variable in a lot of patients? Desensitization versus sustained unresponsiveness. So, what is the immunological switch that converts temporary protection into durable tolerance, particularly in food allergy OIT? And how can we best personalize, because currently allergen immunotherapy was the first thing that did teach us personalized therapy from the last 100 years, but can we move beyond the one size fit all approach? So in conclusion, we have an AIT that is that guides immunological transformation from a pathogenic Th2 Ig mediated response to a robust multi-layered and durable state of tolerance. The universal pillar of success are the T regulatory cells, and the IL-10 is a dominant cytokine that causes tolerance, and IgG4, IgG1 are the major blocking antibodies. The field is again at an exciting inflection point with innovations of the intra lymph node immunotherapy, adjuvant formulations, and recombinant hypoallergens that promise to induce tolerance with even greater precision, safety, and speed. And the ultimate vision is a personalized immunotherapy offering the prospect of a true cure for all our allergic patients. Thank you.
Thank you, sir, for that very informative, lucid, and a beautiful presentation on the immunotherapy. It was really a very great session, sir. Mainly the most funny and the eye-catching was that slide on T-Rex cell, IgG4 and Amitabh Bachchan, sir. It was really a very great slide, sir. Thank you, sir. With this, we end our sessions of today. We had a really very enriching sessions today with beautifully highlighted how immunological pathways are intricate, contribute to the allergic disorders. In fact, all these talks started from the story which went just beyond the T cells and the B cells, which involved the complex interplay of all the cells, including the epithelial cells, the dendritic cells, the innate lymphoid cells, basophils, eosinophils, and which all shape an allergic response. There was a good insight into various roles of various biologics, various biomarkers, the monoclonal antibodies, the targeted therapies which are now involved, the recent updates into this, and then the discussion on the allergen immunotherapy, which has shed not only on the immunological basis, but also how various therapies are now going on working and what are the future innovations which are available now. It was a really a great session today. Thank you to all the presenters. Now I would like to hand over this session to Dr. Neeraj sir for the concluding remarks. Thank you, sir. Over to
Thank
you,
you,
sir.
Dr. Smita. Thank you, Dr. Smita. I think wonderful moderation, and I must say that the we are practicing allergy for I think now nearly a decade. But since listening to all these presentations, going in deep about the immunology of allergy, it still sees that there is a lot to learn, and lot to learn. So we all are actually growing, learning, and teaching and interacting with each other. And wonderful sessions means like nothing short of that. And I'm actually feeling very proud that out of the 4 sessions, the 3 sessions have been delivered by our own DPA alumni. So I always feel proud that when our own students they excel and performing much better than me, much better than us. So what great feeling you can get means like after listening to these presentations, beautiful presentations. So I think Dr. Shebna, Dr. Dinesh, Dr. Guru Raja, and then Dr. Kunal is just master of masters. So there is no doubt about that. So he is just super. So I think everything was so great. Now the stage is really set that we will be moving a little bit away from allergies now, and we will be talking a little bit more about allergy mimickers tomorrow, about how the same presentations can manifest to us in conditions like immunodeficiencies or probably some chronic infections or autoimmunity, and then a little bit more talk about biologicals in the 3rd episode of Applied Immunology. So with this, I would like to conclude here, and once again would like to thank every one of you and all the listeners for such patience listening. Thank you. Thank you.
Thank you.